So CPC, complex primary cases, is the topic. There is a primary complex totally arthroplasty is a demanding knee replacement because of the presence of severe deformity, instability, and bone defects. Primary complex total knee replacement, it almost accounts for 2 to 18% of all the total knee replacements. And it is because of the severe osteoarthritis or inflammatory arthritis, infections, or post-traumatic conditions, as you can even know. So most often the results are almost comparable, but at times they can be less satisfactory when compared to the standard case of total knee replacement. So first we would like to know about the bone defects, how they happen. Less often because of the congenital anomalies like defects of femur and tibial congenital anomalies, acquired bone defects like severe osteoarthritis, which results in commonly in severe varus deformity because of the posteromedial defects happening, and severe valgus deformities with central and lateral plateau defects commonly happens in the rheumatoid arthritis. And it's also because of osteolysis or osteonecrosis, infections, and arterial bone loss because of the implant removals or the revision implants, total extension while you remove the primary implant, or the post-operative HTO cases wherein there is posterolateral corner defects. So we classify this as different classifications based on the size, site, and the margins of the metaphyseal region. So based on the size less than 5 mm, less than between 5 to 10 mm, and more than 10 mm. This is Rand's classification. Based on the site, Dove's classification, central and peripheral. And based on the margins described by Insal, the defects are whether they are contained or uncontained. Contained is with the intact cortical rim around, uncontained is loss of cortical rim. So this is the Anderson Orthopedic Research Institute classification. It depends on the metaphyseal quality of the bone. Intact metaphyseal bone, that is, it is a contained defect wherein we can as well get away by just doing the standard total knee replacement. And type 2 is cortical bone loss in metaphysis. Usually it is uncontained. 2A and 2B. 2A is either femoral or the tibial loss, that is the defects in the femur or the tibia. And type B is both the femoral and tibial bone loss. And type 3 is significant metaphyseal deficiency, that is the defect is more in the metaphysis. When the defect is less than 5 mm, usually we will get away by just cementing technique. 5 to 10 mm cementing plus screw fixation or bone graft plus cementing technique. 10 to 15 mm metallic augments. More than 15 mm usually we just bypass the metaphysis. By latestly we are just by doing the metaphyseal cone or the sleeve technique. Sometimes we can as well use the megaprosthesis as we do it in the tumoral situations. So these are the images of some various knees with the defects, very classical big defects. So intraoperative picture. So how do we get away with these defects which are as classified now? So we need to restore the longitudinal, angular and rotational stability. Restoration of the joint line. We used to be having classical teaching of We used to listen always to our teachers saying that totally replacement is a soft tissue reconstruction rather than the body procedure. So, restoration of the joint line, restoration of the soft tissue stability is just by restoring the soft tissue stability around the joint. So, joint line maintenance is very important. So, while you take the cuts in the femur and the tibia side, this you should keep in mind. Better always keep a rim of the meniscus